Okay, so I'd like to start the KGRI lecture series. My name is Masato Yasui, Professor of Pharmacology, School of Medicine, and also the Director of Keio University Global Research Institute. It's my great pleasure to invite Professor Louis PÉPIN from the University of Grenoble, Alpes. He's a professor of clinical physiology and head of physiology, sleep and exercise clinic at Grenoble Alpes University Hospital. And Keio University and the University of Grenoble Alpes, we started a tight collaboration since a couple of years ago. And actually, last couple of years, I've been visiting Grenoble 3 times already. And last week, actually, we made a MOU between Grenoble Alpes and Keio. Especially, we focus on the 3 areas. One of them is the sleep medicine. And Professor Pépin is the expert on the sleep medicine and play a very important role in the EU and also all over the world. And today, he's going to talk about the big data analysis for supporting integrated care in sleep apnea. His talk, I hope, will cover our future collaboration. Thank you.
Yes, thank you very much. And it's really a great pleasure to be here to present this lecture. And I would like to thank Professor Yasui. It's great to establish a collaboration between Grenoble and Keio University. And I am sure in the next year we will have some very interesting collaboration. So thank you very much. So we are going to speak of the interest of using big data analysis for understanding and supporting integrated care in sleep apnea patients. I will start with some slides of introduction. This is a recent review in the New England Journal of Medicine, and just showing what you already know, that the modern management of patients with chronic disease, we are going to have more and more information coming from some wearable device, some smartphone application. This morning I met, for example, a doctor with a smoking cessation program supported by a smartphone application. We are going to use more and more electronic medical record to have very precise information regarding the patient and the comorbidities. And this is going to be very important to establish a better relationship between patients and clinicians. The first consequence is that we have what we call a big data avalanche. We have a lot of information, completely heterogeneous. So we have the electronic medical records. We have some imaging, for example, CT scan, MRI. We have a lot of omics data from different sources. We have the smartphone application. Very important, we have also some administrative databases. And I will show you an example. We have also some social media information, Twitter, and I will show you the interest of this social media in medical, in the medical field. At the end, there is a big challenge to put all together all these different heterogeneous information, and we can get additional data regarding phenotyping or phenomapping of the patient, some predictive risk models. I will show you an example of pharmacovigilance data using very large database, a better results allocation, the appropriate cost for the appropriate phenotype of the appropriate patient, and we will develop precision medicine. Before starting with sleep apnea, just an example of social media and health. Do we have epidemiologists in the audience? So if you are an epidemiologist, you want to establish a cohort, you need 10, 15 years to have an answer. And now, probably some of you are taking pictures during your lunch or dinner, and it's very easy by working on this picture on Instagram to reproduce the obesity map in the different states in the US. And this is another nice example using Twitter. So this is a classical cohort in a county in the US looking at the mortality rate in this county. You have the classical epidemiological study looking at obesity, hypertension, diabetes, the classical risk factors. And you can see that these risk factors are related, smoking also, to mortality. But if you look to the tweeters of the same population, you can see that tweeters, including hostility, aggression, depressive mood, fatigue, etc., are the best predictor of mortality. So you have just to look at Twitter and you can anticipate the prognosis of the patient. We can anticipate that Mr. Trump has not a good prognosis, you know, but again, this is going to completely change the way to conduct clinical trial. Now, obstructive sleep apnea. This is a review we did published in Nature Review Disease Primus, summarizing what is the disease. Sleep apnea, it's the repetitive occurrence of pharyngeal collapses, complete or incomplete, at this level associated with snoring and essentially sleepiness and some cognitive dysfunction. But very importantly, it's also a systemic disease with a lot of cardiovascular and metabolic comorbidities. And if you want to take care appropriately to a sleep apnea patient, you have not only to treat the number of abnormal respiratory events during sleep, but also to address the complication, including cardiovascular and metabolic comorbidities. What is the magnitude of the problem? This is a collaborative study we did published last year in Lancet Respiratory Medicine, trying to establish the prevalence of sleep apnea worldwide. And we estimated from the available data, not so much data in Japan, I should say, that nearly 1 billion people worldwide are suffering from sleep apnea of different severity. So this is one of the most frequent chronic disease. In Europe, we estimate that more than 30 million people are currently undiagnosed and untreated. And what is the cost associated with sleep apnea? This is an independent study mandated by the American Academy of Sleep Medicine. And when you look at the cost of the disease compared to other chronic disease, you can see that the annual cost is more than $100 billion in the US, close to hypertension, coronary heart disease. So the associated cost for sleep apnea, including a traffic accident, comorbidities, complication, are very high. And in this review, trying to identify what are the challenges to be faced in sleep apnea. One of the most important challenges is to have new diagnosis algorithm and surrogates of sleep staging, and we are working together with Keio University to develop specific algorithm for automatically scoring sleep stages. It's impossible to diagnose 1 billion people with very complex techniques inside the sleep lab. The classical diagnosis tool is polysomnography. In lab, you have a lot of sensors. You have EEG, you have flow, you have snoring, you have position, you have oxygen saturation. You have a lot of information. But this is associated with very long waiting lists. For example, in our laboratory in Grenoble, we have a mean duration of 7 months before have an access to the sleep lab. So you have inequalities in access to care. It's really boring and labor-intensive for the technicians scoring manually during 2 hours. I met this morning the technician or the doctor, I don't remember, in the lab. It's really complicated, and there are some patient acceptance issue. So we need to develop new diagnosis tool for sleep apnea. And this is an example of what we are doing currently. This young guy is suffering from sleep apnea, and we are just using a single sensor to assess mandibular movements. Because when you are snoring, or when you are doing respiratory effort, you are going to move the mandible in a very specific way. And just by measuring a mandibular movement, you can get respiratory effort, sleep fragmentation, etc. And this is an ongoing European project. So you are at home, you have your smartphone application, you are going to enter your name, your medication, your comorbidities. You can identify the sensor position with the smartphone application. This young lady is obviously not suffering from sleep apnea, but this is just an example. And then during the night, you have automatic data transfer in the cloud with very good data privacy. And we have developed a machine learning algorithm to score apneas and hypopneas. And at the end of the morning, you have the result of the sleep study available both for the patients and for the clinicians. And we did a comparison between this very simple technique to polysomnography in a large population of nearly 400 people. And the paper was published 2 weeks before in JAMA Network Open, showing that we are really able to identify normal subject and mild to moderate OSA just by using the mandibular movements. We have more discrepancy for the very severe population, but we continue to work on the algorithm. And when you are very severe, it's not so important to score you with 50 or 65 events. You have a clear severe sleep apnea. So we need in the field of sleep apnea new tools, including machine learning, artificial intelligence, innovative sensors, and we hope that using EKG with the collaboration in Keio, we will be able to have a sleep scoring very easily and to identify sleep apnea. So we are going to share some sleep study to do that. Another unique opportunity of sleep apnea. The first-line therapy for obstructive sleep apnea is CPAP, continuous positive airway pressure. So you remember that you have pharyngeal collapses during sleep. So to reopen the upper airway, you can use a mask and push pressure inside the upper airway to reopen the upper airway. And you are going to suppress apneas and hypopneas to normalize sleep and to treat the patient. And what is unique in chronic disease is that all these CPAP devices now, they have the capability to transfer every night data regarding treatment efficacy. So we have million people treated over the world with the data of CPAP nightly usage, adherence, leaks, and detection of residual events. So this is really important for the CPAP and the obstructive sleep apnea patient follow-up, and I would like to show you some examples of this. So first of all, when you are discussing with the health authorities, you can provide data in real world regarding adherence. This is a paper we did publish using the telemonitoring in the US in more than 2 million and 60,000 patients treated by CPAP. And you can see that the mean usage during the night was 5 hours, with 75% using the CPAP every night. What is interesting also is you can see that the adherence was not the same in the different states of the US. The lower adherence in California, the higher in the center of the US. This is probably reflecting the number of sleep labs. In California, you have a sleep lab in every street. So when you are depressed, tired, for any symptom, you have a sleep study. But at the end, a lot of people are treated with CPAP, and probably they do not require CPAP. That's why the mean adherence is lower. Here you have no or less sleep lab, so you are highly motivated and when you are going to a doctor. So now in the American recommendation, there is a recommendation to use systematically telemonitoring of CPAP device for this patient with sleep apnea. Another example of this telemonitoring data. We have two main type or subtype of sleep apnea. The classical one with upper airway collapse, obstructive sleep apnea, and we have also some patients with unstable respiratory control exhibiting central sleep apnea. So when you are treating one obstructive sleep apnea patient with CPAP, you have a percentage of patients developing central sleep apnea on treatment. And we have also a diagnosis, some patients having not only OSA, but also coexisting central sleep apnea. And sometimes there is an improvement under CPAP. Sometimes there are persisting central sleep apnea. Just an example in the sleep lab. This is a one-night recording. So you have the hypnogram with the different sleep stages. You have the oxygen saturation during the whole night, and you have transcutaneous PCO2, and this is, I think, 5-minute recordings. So you can see the sleep fragmentation with the microarousals, and very typical obstructive hypopneas at the beginning of the night, associated with limited desaturation. But in the second part of the night, you have typical central sleep apnea with Cheyne-Stokes respiration, waxing and waning, crescendo, decrescendo. So in the same patient, and it's quite frequent, you have both obstructive and central. And in this case, it's difficult to anticipate what is going to be the impact of CPAP treatment. So when you look at the available study, there were a significant number of studies, but the prevalence of central apneas under CPAP, huge variation from 5% to 20%, depending on the methodology of the studies, and a very limited number of patients. So we have 100 patients in the study. So the question was, what is the prevalence of emergent, persistent, transient sleep apnea under CPAP therapy in a large unbiased population? And when you are in the sleep lab, you have only the measurement during one night. When you have telemonitoring with the CPAP, you have data every night. So we did an independent data analysis, and if you are interested, you can look at the Medics Cloud. We have a website, and you can find. So it is a collaborative study between colleagues in the US, in Australia, and Germany, and we have the help of a significant number of data scientists and statisticians. Actually, there are more than 100 data scientists working on this project. So what we found, we look at telemonitoring data of 133,000 patients, and we look at the evolution of residual events during the first 3 months. And we distinguished 4 different phenotypes. You have significant, the majority of the patients were perfectly treated by CPAP. You have a phenotype normalizing the central events on CPAP, and you have patients developing central apneas or keeping with persisting central sleep apnea. And it is interesting, but just looking at the data of the CPAP devices, you have the exact percentage of the different phenotypes, and you have a sample size, a very large sample size compared to the previous studies. And what was interesting also is when you look at the population with central sleep apnea, the risk of therapy termination was higher in this population of non-adherence, of stopping to use the device. So when you have in your CPAP device telemonitoring more than 5 events per hour, you can anticipate some difficulties for continuing CPAP. But the limitation of this big data from CPAP device is that you have only age, gender, and the data of the device. You have no information regarding the clinical data. But what we did also was to look at how to treat this patient. So the classical treatment is CPAP, and when you have central events, you can use another treatment, is adapted servoventilation. The device is in capability to change the pressure support to suppress the central events. And what you can see, if you using the same data set, so more than 100,000, if you have persistent central sleep apnea, progressively you are decreasing over time the CPAP usage. If you move to adapted servoventilation, in the big data set, we look at patients shifting from CPAP to adapted servoventilation, and we can see an increase in adherence and a normalization of central events. So only using big data, you have a very large clinical study, and you do not need to include during 5 years or 10 years consecutive patients shifting from a CPAP to another treatment. So sleep apnea is really a complex disease. It's not an homogeneous condition. All these people are suffering from sleep apnea. This one is a young guy with retrognathia, non-obese. This one is a typical middle-aged sleep apnea patient with metabolic, with obesity. This is a COPD plus sleep apnea, what we call overlap syndrome. This is a cardiac failure patient with probably more central sleep apnea. And this one is acromegaly. This patient has acromegaly. It's a rare disease, changing the maxillofacial structure and also associated with sleep apnea. So now we are using the large national registry to do what probably some people in the audience, cluster analysis. We try to define homogeneous subgroups of patients. And this is a study in nearly 20,000 patients. And at the end, we have 6 different clusters. And now we have the same studies at the European level. You have youngest people, symptomatic, non-obese, with low comorbidity, but you have also oldest people, obese, with severe AHI, no symptoms, many comorbidities. In this situation, you can anticipate that these people are not going to use CPAP. They are not symptomatic. They do not understand why it is important to be treated for sleep apnea. And you can describe some different population in terms of risk factors, of comorbidities, and you can see that among the different clusters, you have different levels of sedentarity, you have different degrees of obesity, etc. So when you are planning the treatment of this patient, you have to manage not only sleep apnea, but the associated risk factors and the comorbidities. And going back to the phenotypes of residual events under CPAP, using this kind of very large database, this is a study done in 12,000 people, using electronic medical records. Now in our daily practice, we are entering all the new patients in the same electronic medical records. So we have high quality data we can share for collaborative studies. And if you look at the risk factors for persistent event under treatment, main condition, cardiovascular comorbidities are significant, and also wearing not a nasal mask, but a facial mask. And I don't know if you are using a lot facial mask in your routine practice, but in some patients, you are going to put the mandible and to increase the number of respiratory events. So again, using telemonitoring, you can get now, when we are doing our consultation in sleep apnea patient, we systematically have a look on the telemonitoring data from the CPAP devices. And this is just to show you, this is a CPAP titration in a sleep study. During the first part of the night, the patient was using a nasal mask, and the pressure to correct the abnormal events was 8. But the technician said, oh, he has some leaks around the mask. I will change for a facial mask. And you can see that in this situation, you have to increase the pressure until 16. And now you can see that just using telemonitoring. You have 1 year of telemonitoring. This is the number of residual events, 5. Every night you have a value on the web platform. And this is the same story. The patient at home was using a nasal mask. The technician during the home visit, he said, oh, there are some leaks. He changed to a facial mask, and you can see the increase in abnormal events. So when I saw the guy at the consultation, by opening the telemonitoring platform, I can say, please be back to the nasal mask, because the control of the disease is not good by using a facial mask. And we are going to see a lot of things now with telemonitoring. If you are not sleeping at home, during the weekend you don't want to use, for example, your mask because you have a new girlfriend. In this situation, you can see everything on the telemonitoring. This is also at high potential. You can detect some acute events with telemonitoring. This is again 1 year, and this is the number of residual events. You can see that something occurs with a huge increase in residual events, a decrease in adherence in this patient. And I did receive a letter at this time saying this patient has been hospitalized for cardiac failure. It was a patient with resynchronization therapy, a pacemaker for resynchronization therapy, and owing to an infectious disease, there was a withdrawal of the resynchronization therapy, a deterioration in cardiac function, and a lot of central sleep apnea. So CPAP was no more effective. Currently, 6 months before decision, we try now to implement some artificial intelligence to have automatic detection of these changes on telemonitoring, to have some alerts and to detect cardiac failure. So in the future, I am sure the different CPAP companies and also academic people who will have every morning at the beginning of the day several alerts saying this patient on CPAP potentially is in acute condition for cardiac failure, just by looking to the telemonitoring. So at the end, in the future, There is a special issue of Nature Medicine regarding artificial intelligence. It's a very good review paper, fascinating. So the goal is to put together, as I was saying at the beginning of the talk, a lot of different information to provide a better understanding of the patient phenotype, improve artificial intelligence, and then implementation in healthcare. And another example, do we have cardiologists in the audience? No. You know, we and others, we have validated the detection of sleep apnea using pacemakers. Because, you know, in pacemakers, there is a thoracic impedance sensor for measuring ventilation, because when you have a pacemaker and you are doing exercise, the rate of stimulation should change. And now every brand, Livanova, Medtronic, Boston Scientific, they are including a detection of sleep apnea. So if you have a collaboration with the cardiologists, they don't care. They don't even have a look on the results, but in the majority of the pacemakers, they have the information regarding sleep apnea. And also, this is providing big data, because you can have a look on this patient. When you click on the apnea information from the pacemaker, every night you have information regarding sleep apnea. And in this case, you can see that this patient, every night, the number of apneas and hypopneas was close to 60 per hour, so very severe sleep apnea. And the interest is that you have also in association a detection of arrhythmic events. And this is an example of a patient before CPAP treatment with the pacemaker. We start CPAP here, and you can see just by looking at the pacemaker, the normalization of the respiratory events during sleep. And more interestingly, if you look at the number of arrhythmias, in this case, atrioventricular block, in the 3 months before CPAP, 825. In the 6 months after CPAP treatment, only 300. So you have the demonstration in real life situation that treating sleep apnea in this patient is reducing the number of arrhythmias. And now we are working on very large databases with every night information. And we have a recent publication showing when you have a patient with untreated sleep apnea detected by the pacemaker, you have more atrial fibrillation, especially during the night. So again, very important and interesting information coming from big data. Another example, the VG-base. This is the WHO pharmacovigilance database. So you have million individual case safety reports from a lot of countries. And we are doing as over what we call disproportionally analysis. You have case, non-case, and you can identify some medication related to sleep apnea. For example, we have identified ticagrelor. Ticagrelor is the first line antiplatelet therapy after acute coronary syndrome. It's AstraZeneca is not a fan of publication, but it's very important and very interesting. And there was a first publication in New England. This patient under ticagrelor, you can see typical central sleep apnea. This is a 20-minute recording. And we are able to measure ventilation. And this paper is showing that when you are using ticagrelor, not in all patients, but in some patients, you have an increase in ventilation, you have chronic hyperventilation, and you have central sleep apnea. As you are, you have in altitude, you are hyperventilate and you have central sleep apnea. 1 week after discontinuation, a decrease in central sleep apnea, an improvement in hyperventilation, and 1 month after discontinuation, normalization of ventilation, normalization in the ventilatory responses. So what we did, we used the WHO pharmacovigilance database, again using 1 million of reported cases, and we found that compared to other antiplatelets or aspirin, the risk of sleep apnea is clearly higher with ticagrelor. And we have several publications. Recently, we have published the same thing for gabapentinoids, for example, for baclofen, a treatment for chronic alcohol consumption in France. So using this huge database of pharmacovigilance, you can identify a link between a disease and medications. And for ticagrelor, so when you look at the mechanism, ticagrelor, there are some receptors at the respiratory centers and inside the pulmonary fibers. This is for the respiratory physician. So this is producing hyperventilation, increased chemosensitivity, and central sleep apnea. So we have not only the information of the pharmacovigilance database, but we have also now an understanding of the mechanism. Other insight from the big data, very interestingly, we have now patients' engagement tools. We did discuss this morning this smartphone application to increase adherence and to increase, and we spoke around the Dream Mapper of Philips, but I will show you some additional information from another CPAP company. And another company of CPAP, ResMed, not Philips, but you have the same kind of information. And we have patients completely obsessed by this. You can every morning have a note. You have a CPAP adherence, you have leaks, and you have also the number of respiratory events. And for example, if you have too much leaks, you can have an access to some videos showing you how to put your mask, how to improve your treatment. And again, if you look at this data, this is a propensity score analysis in, you can see more than 128,000 patients, some using telemonitoring alone, and some using telemonitoring plus the smartphone application. And what is clear, when you are using the smartphone application, you have a better adherence with CPAP. It's not a randomized controlled trial, but if you are using this kind of information every morning to support your adherence, it's probably very interesting. And the paper is not published, but is in press. This is the same study in the US, the Medics Cloud Group, with more than 20,000 children in the US treated by CPAP, especially in the US with obesity. They have a lot of young children and adolescents treated by CPAP. And you can see that adherence is lower in the different classes of age compared to the adults. There are also some variation between the different places in the US. But what is really interesting that the adherence, the lower adherence is occurring in the adolescents. And this is really interesting. You know, when you have parents using the smartphone application, the engagement tools, so the parents are using in the morning to look at the efficacy of the treatment in the children, and you can see the huge difference. This is with the smartphone application, without in small children, 6 to 12, 12 to 15, 15 to 18. So this kind of support is probably very interesting, and it's free. It's developed by CPAP companies. I think it would be great if physicians or academic institution can develop their own engagement tools. So again, with a very, the studies of CPAP adherence in children, the maximum sample size before this study was 200 patients, and now 20,000. So it's a huge difference. This is a study we did published last year, a randomized control trial. You remember that sleep apnea is not only collapse. You have not only as a respiratory physician or a neurologist to use CPAP, you have a lot of comorbidities in these patients. And it's also important to manage sleep duration, physical activity, blood pressure. And in this study, we were using a multidisciplinary web platform with monitoring at home of the CPAP telemonitoring, but also an actimetry for physical activity, self-measurement of blood pressure, and the patient were using a tablet to describe the improvement in symptoms, or also the side effects related to the device. And as a physician, we have direct access to the platform to get this information. So it was a randomized control with approximately 150 patients in every arm. But as a physician, sorry, it's in French, but when opening the web platform during your consultation, you can see the different side effects. And automatically, for example, aerophagia, there was an information automatically sent to the home care provider to manage the side effect, leaks, etc. And also, you have the oximetry automatically transferred to your web platform, the number of steps per day, physical activity, and the measurement of blood pressure. So it's easy for you as a doctor, you have all this done. You have just to discuss with the patient and try to improve the information. And interestingly, just monitoring is not enough, because even monitoring physical activity in this study, patients treated for their sleep apnea, they do not increase their physical activity. So we need not only to monitor, but also to develop some rehabilitation programs. And this is an example of a European study we did conduct in Grenoble. So we included patients already treated by CPAP. We developed an application for prescribing exercise. And we propose of the patient different settings for doing exercise. We paid for a private sport club for the patients. This is on a river in Grenoble, electric bike, and also rehabilitation center. And we did ask to the patient, what is your preference? I should say it was not rehabilitation centers. And it's good because the cost of rehabilitation center, as you know. And interestingly, they have the application and also the monitoring of physical activity. What was great for the patient, they were able to see that when they are doing physical activities, the blood pressure went down, etc. So it was highly motivated. But I should say that during the 3 months of the study, it was perfect. But when we stopped the rehabilitation program, the majority of the patients also stopped physical activity. So the question is to have a long-term effect with these rehabilitation programs. So I would like to finish my lecture, and we have time for questions. This is a recent editorial we published, I think, 1 or 2 months before. We move from the traditional CPAP model. I am a respiratory physician, you are a sleep apnea patient. I say you have to wear your CPAP mask and to be adherent. And now we should move to a completely different organization. Using big data, we can have a better understanding of the different cluster of phenotypes, the different subgroup of patients. We need a multidisciplinary team, sleep physician, care providers, different specialties, but also in the US, more and more dedicated sleep nurses and non-physician. We have to use at maximum the e-health, e-health records, electronic medical records, telemonitoring, social network engagement tools. For example, in the US, one of our colleagues, Dr. Wang, in Kaiser Permanente, he has an incredible program, all the cost in the private insurance, all the information during the whole life. And we have also to develop patient-centered care with education, self-management, and not only CPAP, but also lifestyle intervention, including diet and physical activity. So thank you very much for invitation, and pleased to have questions.
Thank you very much, Professor Pépin. So we have a lot of time for question. Any questions from the audience? Yes.
Thank you for the very nice presentation. It's very interesting for us. So actually, so in Japan, so now we have the OSA patient, maybe so 600,000 patient we have. So of course, even in Japan, so the patient is waiting for the PSG 1 or 2 months before treatment. Yeah. Yes. So sometimes we find the patient who with the upper airway resistant syndrome. Yeah. Yes, using the PSG. So we are wondering we need to be treated those patient or not. So could you tell me about that?
Yes, these patients often are really symptomatic. The severity of oxygen desaturation is not so high, so the cardiometabolic risk is limited, but probably this patient need to be treated. Usually what we did, we are using CPAP for several months just to check whether or not when you treat this, you have a great improvement in sleepiness, in fatigue, etc. And when it is the case, sometimes we move to oral appliances because in general, these people are lean without comorbidities, so we can also use, but we treat these patients, yeah.
And then, so when you treat those patients, so you use the CPAP, right? And then, so do you have another method to be treated to the patient?
Yeah, mandibular advancement devices, and now there are some new positional therapy devices.
Positional therapy.
Yeah. So in this patient, it could be interesting, yeah.
Okay, thank you.
Oh, sorry. Oh, how about Nastent? Use Nastent to patients.
You know, I have a story with Nastent. I am not sure it's a good story, but we tried to use Nastent. I was convinced that patients are, everybody knows what is Nastent. You use a tube every night, and you are intubating yourself. So you protect the upper airway because you have a tube inside the pharynx. And Nastent has been developed in Japan, and we try, but we don't have good results, I should say. And perhaps part of the explanation is differences between, as we discussed this morning, between facial appearance of Japanese versus European or Caucasian. So the length of the tube was probably not enough. Yeah, especially to protect. Yeah. So, and we have not published the results, but it was not convincing. But I was surprising the tolerance of the patient was good. Yeah. It looked like for me very difficult every evening to intubate myself, but.
Any other questions?
My name is Dr. Endo. And I have...
We met before.
Yes.
Yeah.
I have 4 clinics, 3 in Tokyo, 1 in Sapporo. And we are opening the sleep clinic in this university.
Yeah, okay.
And we gathered 20,000 patients in a 4 clinic. And right now we are using CPAP over 2,000 CPAP machine. And we carefully checked what type of sleep apnea. And I have only 1 central sleep apnea.
Yeah.
And I'm very surprised to see why there is only a few central apnea in our clinic.
Yeah. In my opinion, it is highly related to the people who are referring the patients. Because if you have mainly a cardiologist referring a sleep apnea patient to you, you are going to have a high level of central sleep apnea. If it is only ENT surgeons, for example, or general practitioners, you have less cardiovascular disease. And year after year, we have seen in our lab an increase in central sleep apnea because we have more and more complicated patients with comorbidity, and in this situation, we have more central sleep apnea.
And I think that there is only a few sleep laboratory in Japan. And so the many hospitals and the many at the university hospital introduce us to check what type of sleep apnea. So if this character is only in Japan, it would be very interesting.
Yeah, that's why, for example, you remember the map of the US. We have submitted a comparison of adherence. The paper is submitted now with our colleague in Mexico and in Brazil. And for us, in terms of collaboration, it would be great if you can have an access of the data in Japan regarding CPAP telemonitoring, because you have a very close follow-up. You are seeing the patient every month at the beginning of initiation, and my understanding is the mean level of adherence is very high in Japan, but the cost is probably also very high because you have many, many consultations. And now in France, the health authorities, they said, yes, we are going to pay for telemonitoring, but you are not allowed to see the patient more than once per year, except if you have an alert. So it's a completely reshaping of the organization of care. But yes, I would be really interested to look at the data of telemonitoring in Japan. Yeah? We can have different typology of patient, different adherence. It's also interesting in Japan, you have a lot of different location and different follow-up. It's not the same in Tokyo, in the north, in the south. So yeah, if we can have an access to the telemonitoring, it's interesting. And for example, in Mexico and Brazil, you have to pay for your CPAP device. So the adherence is very high, and even in these countries, using the engagement tool with the application, there is an increase in adherence. So
we have already have a big data.
Okay, so great. You have a look on the data already on CPAP?
We are gathering the big data,
yeah.
but not analysis yet.
Yeah, it could be really important, even for the discussion with the health authorities, for reimbursement and for allocation of resources. It's really important to have a look on this data.
But that tendency, I mean, limited number of the central sleep apnea is very low. It's quite unique to Japan or any other Asian countries. They have the same tendency.
Because I'm so surprised why only a few the central apnea is existing in Japan, and so
I think the criteria is not so complicated.
No, but
Not so complicated. But I have only one central apnea among the maybe over 5,000 patients.
Yeah.
I didn't know.
Any other questions? Could you introduce your institution, I mean, Center for Sleep Medicine at Grenoble? Because I visited and so impressed how big and well organized.
I should have had some slides. I have no slides. But basically, our group, we try to have a translational research activity. So we have some basic science activity. We have some rodent models exposed to intermittent hypoxia, mice, rats, etc. We have a cellular model exposed to intermittent hypoxia. If you are interested, we have also an hypoxic tent, so you can try sleep apnea yourself. During 40 nights, you can be exposed to intermittent hypoxia, and we are doing this especially in students after ethical agreement, obviously. And we have also a large panel of clinical research activity. And now we have a sleep lab with 8 beds. I think we have visited the sleep lab. So 6 nights per week, we have 8 polysomnography in the lab. And we have also some ambulatory activity. And in the town, we have another center only dedicated to ambulatory measurement with 6 polysomnography ambulatory. So this is a quite large activity. And even with this, we have, as I said, 7 months waiting list. So, but we are adjusting. For example, if you are a truck driver, you are not going to wait. But if you are a young man with simple snoring, but yes, I agree. It's a surprise that you have no more sleep lab in Japan. But perhaps you are right, because in my opinion, some of the sleep lab are going to collapse, because it was the case in the US. Because now Medicare is reimbursing only home sleep testing to reduce the cost. And some of the sleep labs in the US, they are in great difficulty. So probably we have to keep some beds for very complicated cases, but to increase the number of innovative tools to diagnose sleep apnea and to follow sleep apnea.
Thank you. Any other questions? It's okay? Okay, thank you very much.
Thank you very much. Thank you.